Hello, my name is Kevin Fernando and I'm a GP partner at North Berwick Health Centre near Edinburgh, and I'm also Education Director for GP Notebook Education. Today I'm going to talk about progression to type 2 diabetes mellitus in women with established gestational diabetes mellitus. Now, we're increasingly seeing women of childbearing age either at high risk of developing type 2 diabetes or with established type 2 diabetes. And as we all know too well in primary care, pregnancies complicated by diabetes are associated with adverse maternal and fetal outcomes. Now, during 2015, NICE produced some new diabetes in pregnancy guidance, NG3, which, amongst other key clinical recommendations, gave us new, tighter diagnostic criteria for diagnosing gestational diabetes. So now we should diagnose gestational diabetes if a fasting blood glucose is greater or equal to 5.6 millimoles per litre, or a 2-hour blood glucose post the 75-gram oral glucose tolerance test is greater or equal to 7.8. So, as you can see, these criteria are much tighter than the criteria we would use to diagnose diabetes in the non-pregnant individual. And finally, and importantly, gestational diabetes significantly increases the risk of future type 2 diabetes, and long-term follow-up is required for all women diagnosed with gestational diabetes. Now, over the years, we've lacked high-quality evidence to allow us to quantify this increased risk, especially in ethnically diverse populations. But what we have now is an updated meta-analysis and systematic review published in the BMJ during May 2020 that suggests a near tenfold increased risk of type 2 diabetes in those with gestational diabetes compared to healthy controls. And unsurprisingly, the authors are suggesting we focus on postpartum screening of type 2 diabetes in primary care in those with established gestational diabetes, as well as, of course, encouraging lifestyle and dietary change, and perhaps even considering pharmacological intervention as appropriate with drugs such as metformin. So how can we do this in primary care? Well, what NICE NG3 suggests is, of course, we offer lifestyle advice to all those diagnosed with gestational diabetes, but we should also check a fasting blood glucose around about 6 to 13 weeks after delivery. And this can usefully be tied in with the 6-week postnatal check. Now, importantly, we shouldn't offer an oral glucose tolerance test, or we shouldn't use HbA1c to diagnose diabetes, because the HbA1c assay is potentially invalidated within 2 months of pregnancy because of changes in red blood cell lifespan. And also, when we're assessing that full fasting blood glucose result, we should use the non-pregnant diagnostic criteria to establish a diagnosis of type 2 diabetes. So if that 6-week fasting blood glucose is indeed positive, then we can establish a diagnosis of type 2 diabetes and go down our usual pathways in primary care. But if it's negative, that woman in question actually requires a lifelong, at least annual HbA1c because of her extremely high risk, near tenfold increased risk of developing type 2 diabetes. So this is a great idea for a quality improvement activity for us all to consider in primary care. Have a look at our registers of women with gestational diabetes and ensure they are all under regular follow-up for at least an annual HbA1c.